Hi team, it's Sarah. I'm gonna go ahead and do my video response for module 4. So my scenario is a 78-year-old male in the surgical ICU. He has decent but not debilitating history. He had a hiatal hernia for 20 years that the doctors didn't want to do anything about, so he just lived with it. So at home, he experienced flu-like symptoms, followed by a loss of appetite for 4 days. He developed some abdominal discomfort, but didn't think much of it, just thought it was because he wasn't eating. It increased as the days went on. On day 4, he had a sharp pain that quickly subsided, so he just went ahead and went to bed. He woke up the next morning tachypnic, tachycardic, diaphoretic, really having trouble breathing. The wife was afraid, brought him to an outside hospital emergency room. They did a CT, they didn't like what they saw, so they sent him to us. So he had, come to find, he had a ruptured stomach that had been incarcerated via the diaphragm in the thoracic cavity. He was septic, he had peritonitis. So we're thinking for roughly 5 days he was just brewing this infectious process around his lungs and in his abdominal cavity. So he went to the OR. The surgeons found that his entire peritoneum and the surrounding adipose tissue was necrotic and actually sloughing. They described it like a Slurpee, like they were able to just slough it out, and it was disgusting. So they cultured the samples, and it grew back yeast, Candida. So this patient had a yeast infection pretty much in his entire trunk, around all of his major organs. So we had an ophthalmology consult, and lo and behold, he had yeast even growing in his eyes, which one of our surgeons was telling us that when that happens, it's usually indicative that the yeast is in every organ. So that's when we decided that we needed to have a family meeting. So we discussed with the family that even if we were able to treat the yeast, his peritoneum still was non-existent. And we discussed too that his mental status had decreased to pretty much nothing. He wasn't moving to pain, he wasn't doing anything. So the infectious disease doctors thought that maybe his yeast infection had gone in and around his brain. So that's also very concerning, especially if these antifungals weren't going to work. And also his kidneys were already having trouble. So the antifungals that we were going to give would have hurt his kidneys even more. We decided to go ahead and give the antifungals and just deal with the kidney issues if he had to have dialysis. That's what the family wanted to do. So he's sitting right now in my unit marinating in these high-powered medications. But our problem is he doesn't have a peritoneum. And they explained to the family in the family meeting that there's no such thing as a synthetic peritoneum. You can't grow it back. And what is in there, what's still in there left there, is just a medium for more of this bacteria and yeast to grow. So my, now finally leading into the discussion board here. So of chapter 1 in the Chinn and Kramer book, it discusses the different types of knowing. So in this situation, my empirical and my ethical knowledge overpower and run wild, quote unquote here. The science behind this case is clear cut. There is only one end option here as far as I can see. When a case is this clear cut from the start, despite life-saving measures or miracles that our physicians try to perform, I tend to leave my emotions out of the situation with more ease. I inadvertently become more of like a black and white nurse with a little gray area for the aesthetic or the personal knowing. I try to be supportive, but I know I can't offer any false hope because that would lead the families down the wrong road. So I don't. And this may be cold, but it's probably as much of a coping mechanism for myself as it is to help the families through these situations. So the ethics in this case is what bothers me. The science leads me to the end point, but then the ethics is what gets me personally. So like I said, in the family meeting, we discussed that there really was no end option for the peritoneum, even if we got the yeast under control. So in my opinion, the right thing to do would have been to say that there's no more we can do to save him. We're sorry, but it's time to start thinking about palliative care, etc., etc. Chinn and Kramer discuss the different roles that doctors and nurses play and how we have very different viewpoints and approaches, but that neither of us are necessarily wrong because we're doing what we personally know is best for our patient. But this is sometimes difficult for me because I'm very headstrong, and I believe very firmly what I believe, and I'll stand up for those things. On page 229, it relays that competence leads to increased quality. Me understanding this complex scenario helps me to be a better nurse by knowing what to look for and for knowing what to report as far as important changes with vital signs, what have you. And it enables me to answer the questions the family has as the family comes up with things that they don't think about during those family meetings with the physicians. And having this empiric knowledge, it really is crucial for critical care nurses, any nurses, because it literally means life or death. Knowing the science is what makes nursing like a medical field, but knowing and practicing the holistic side of nursing is what makes it such a compassion-driven profession. I see my other ways of knowing are clouded and limited by my heavy reliance on empiric knowledge in this situation and other complex scenarios surrounding end-of-life issues. And so I'm looking forward to moving forward out of the critical care arena and into primary care, where I can learn different ways of dealing with different nursing problems and more of like provide from the provider standpoint. I'm ready to dive in there and tackle the other ways of knowing in a situation that I'm not as comfortable in, and it'll test my boundaries. Well, everyone, thank you for watching, and please see my source in the description. Have a nice day.